Tuberculosis, also known as consumption, is an infectious disease. It generally affects the lungs. Most infections show no symptoms. 10% progress to active disease. Symptoms include chronic cough, fever, and weight loss. Tuberculosis is spread from one person to the next through the air when people who have active TB in their lungs cough, spit, speak, or sneeze. People with latent TB do not spread the disease. Active infection occurs more often in people with HIV/AIDS and in those who smoke. Diagnosis of active TB is based on chest X-rays. Latent TB relies on the tuberculin skin test. Prevention involves vaccination with the BCG vaccine. High risk includes household contacts. Treatment requires multiple antibiotics. In 2018, 1/4 of the world's population had a latent TB infection. New infections occur in about 1% of the population each year. In 2022, 10.6 million people developed active TB, resulting in 1.3 million deaths. Most TB cases occurred in Southeast Asia, Africa, and the Western Pacific. Over 50% of cases were in India, China, and Indonesia. History of tuberculosis. Tubercular decay found in an Egyptian mummy. Tuberculosis has existed since antiquity. Evidence in bison remains from 17,000 years ago. Origin in bovines or common ancestor remains unclear. Genetic studies suggest a common ancestor. Infected humans before the Neolithic Revolution. Prehistoric humans had TB around 4000 BC. Tubercular decay in Egyptian mummies from 3000 BC. TB Development of treatments. Tuberculosis caused nearly 25% of all deaths in Europe during the 1800s. It became epidemic, showing a seasonal pattern. The disease was common among the urban poor. In 1815, 1 in 4 deaths in England was due to consumption. By 1918, TB still caused 1 in 6 deaths in France. TB was put on a notifiable disease list in Britain in the 1880s. Campaigns started to stop public spitting, and the infected poor were encouraged to enter sanatoria. Sanatoria for the middle and upper classes offered excellent care. The Alexandra Hospital for Children with Hip Disease opened in London in 1867. Even under the best conditions, 50% of those who entered sanatoria died within 5 years. Robert Koch did not believe cattle and human tuberculosis were similar, delaying recognition of infected milk as a source. Pasteurization dramatically reduced transmission risk in the early 1900s. Koch announced tuberculin as a remedy in 1890. It was later adapted as a screening test for pre-symptomatic tuberculosis. World Tuberculosis Day is marked on 24 March each year. The Medical Research Council initially focused on tuberculosis research. Albert Calmette and Camille Guérin achieved the first success in immunization against tuberculosis in 1906. It was called Bacille Calmette-Guérin, or BCG. The BCG vaccine was first used on humans in 1921 in France. By the 1950s, mortality in Europe had decreased about 90%. Improvements in sanitation, vaccination, and public health measures reduced tuberculosis rates. In 1946, streptomycin made effective treatment and cure of TB a reality. Before antibiotics, treatment included surgical intervention, like the pneumothorax technique. Current reemergence, surgery reintroduced for multi-drug-resistant tuberculosis, removal of infected lung cavities. Signs and symptoms. Tuberculosis symptoms overlap with other diseases. It can affect many organs, not just the lungs. General symptoms include fever, chills, night sweats, and weight loss. Pulmonary TB involves the lungs, causing chest pain and prolonged cough. Extrapulmonary TB affects other organs, common in weakened immune systems. The main cause of tuberculosis, or TB, is Mycobacterium tuberculosis, often abbreviated as MTB. This small aerobic non-motile bacillus has a high lipid content in its cell wall. Interestingly, it divides every 16 to 20 hours, an extremely slow rate compared to other bacteria. Mycobacteria have an outer membrane lipid bilayer. MTB either stains very weakly gram-positive or does not retain dye due to the high lipid and mycolic acid content of its cell wall. MTB can withstand weak disinfectants and survive in a dry state for weeks. In nature, the bacterium can grow only within the cells of a host organism, but M. tuberculosis can be cultured in the laboratory. Using histological stains on expectorated samples from phlegm, also called sputum, scientists can identify MTB under a microscope. Since MTB retains certain stains even after being treated with acidic solution, it is classified as an acid-fast bacillus. The most common acid-fast staining techniques are the Zeil-Nielsen stain and the Kinune stain. Auramine rhodamine staining and fluorescence microscopy are also used. The M. tuberculosis complex, or MTBC, includes 4 other TB-causing mycobacteria: M. bovis, M. africanum, M. canneti, and M. microti. M. africanum is not widespread, but it is a significant cause of tuberculosis in parts of Africa. M. bovis was once a common cause of tuberculosis, but the introduction of pasteurized milk has almost eliminated this as a public health problem in developed countries. Monsieur Canneti is rare and seems to be limited to the Horn of Africa, although a few cases have been seen in African immigrants. M. microti is also rare and is seen almost only in immunodeficient people, although its prevalence may be significantly underestimated. Other known pathogenic mycobacteria include M. leprae, M. avium, and M. kansasi. The latter 2 species are classified as non-tuberculous mycobacteria, or NTM. NTM cause neither TB nor leprosy, but they do cause lung diseases that resemble TB. Public health campaigns in the 1920s tried to halt the spread of TB. When people with active pulmonary TB cough, sneeze, speak, sing, or spit, they expel infectious aerosol droplets 0.5 to 5 micrometers in diameter. A single sneeze can release up to 40,000 droplets. Each one of these droplets may transmit the disease, since the infectious dose of tuberculosis is very small. Inhalation of fewer than 10 bacteria may cause an infection. People with prolonged, frequent, or close contact with individuals with TB are at particularly high risk of becoming infected, with an estimated 22% infection rate. A person with active but untreated tuberculosis may infect 10 to 15 or more people per year. Transmission should occur only from people with active TB. Those with latent infection are not thought to be contagious. The probability of transmission from one person to another depends on several factors, including the number of infectious droplets expelled by the carrier, the effectiveness of ventilation, the duration of exposure, the virulence of the M. tuberculosis strain, and the level of immunity in the uninfected person. The cascade of person-to-person spread can be circumvented by segregating those with active TB and putting them on anti-TB drug regimens. After about 2 weeks of effective treatment, subjects with non-resistant active infections generally do not remain contagious to others. If someone does become infected, it typically takes 3 to 4 weeks before the newly infected person becomes infectious enough to transmit the disease to others. A number of factors make individuals more susceptible to TB infection and/or disease. The most important risk factor globally for developing active TB is concurrent HIV infection. 13% of those with TB are also infected with HIV. This is a particular problem in sub-Saharan Africa, where HIV infection rates are high. Of those without HIV infection who are infected with tuberculosis, about 5 to 10% develop active disease during their lifetimes. In contrast, 30% of those co-infected with HIV develop the active disease. Use of certain medications such as corticosteroids and infliximab, an anti-ATNF monoclonal antibody, is another important risk factor, especially in the developed world. Other risk factors include alcoholism, diabetes mellitus, silicosis, tobacco smoking, indoor air pollution, malnutrition, young age, recently acquired TB infection, recreational drug use, severe kidney disease, low body weight, organ transplant, head and neck cancer, and genetic susceptibility. The overall importance of genetic risk factors remains undefined. Tobacco smoking increases the risk of infections, in addition to increasing the risk of active disease and death. Additional factors increasing infection susceptibility include young age. About 90% of those infected with Mycobacterium tuberculosis have asymptomatic latent TB infections. Only 10% will progress to active disease. In those with HIV, the risk increases to nearly 10% a year. Without treatment, the death rate for active TB is up to 66%. TB begins when mycobacteria reach the alveolar air sacs of the lungs. They invade and replicate within alveolar macrophages. Macrophages attempt to eliminate the bacterium by phagocytosis. The bacterium is enveloped and stored in a phagosome. The phagosome combines with a lysosome to create a phagolysosome. The cell uses reactive oxygen species and acid to kill the bacterium. Mycobacterium tuberculosis has a thick, waxy capsule that protects it. It reproduces inside the macrophage and eventually kills it. The primary site of infection in the lungs is known as the Gon focus. It is generally located in the upper part of the lower lobe or the lower part of the upper lobe. Tuberculosis may also occur via infection from the bloodstream. This is known as a Simon focus, typically found in the top of the lung. Hematogenous transmission can spread infection to distant sites, such as lymph nodes, kidneys, brain and bones. All parts of the body can be affected, though it rarely affects the heart, skeletal muscles, pancreas or thyroid. Tuberculosis is classified as a granulomatous inflammatory disease. Macrophages, epithelioid cells, T lymphocytes, B lymphocytes, and fibroblasts form granulomas. Lymphocytes surround the infected macrophages. When other macrophages attack, they fuse to form a giant multinucleated cell. The granuloma may prevent dissemination of the mycobacteria. However, bacteria use granulomas to avoid destruction by the immune system. Macrophages and dendritic cells in granulomas can't present antigen to lymphocytes. Thus, the immune response is suppressed. Bacteria inside granulomas can become dormant, resulting in latent infection. Granulomas develop abnormal cell death or necrosis in the center. This has the texture of soft white cheese and is termed caseous necrosis. If TB bacteria enter the bloodstream, they can spread and form tiny white tubercles. This severe form, common in young children and those with HIV, is called miliary tuberculosis. People with disseminated TB have a high fatality rate, about 30%. In many, the infection waxes and wanes. Tissue destruction and necrosis are balanced by healing and fibrosis. Affected tissue is replaced by scarring and cavities filled with caseous necrotic material. During active disease, some cavities join to the bronchi. This material can be coughed up and spread the infection. Treatment with antibiotics kills bacteria and allows healing. Upon cure, affected areas are replaced by scar tissue. Tuberculosis prevention relies on infant vaccination and treating active cases. WHO has improved treatment regimens, reducing case numbers. The BCG vaccine is the only available option. It reduces infection risk in children by 20%. Over 90% of children worldwide are vaccinated. Immunity decreases after 10 years. In low-risk areas, BCG is for high-risk individuals.